Hi everyone, I welcome you all to the webinar of Demystifying CMS 0057F. I'm sure this webinar will provide you all the deep understanding of the rules and provisions of CMS 0057F and all the challenges, complexities which payers may face during this implementation. Today, to delve into all these details, we have Anuj Khanna with us, who is a subject matter expert and principal architect with over 20 years of experience in this healthcare industry. Also, Anuj guided several EMR and payers for ONC certifications. Uh, Thank you so much, Anuj, for being part of this. Over to you.
Thank you for introducing me, Shilpa. Hello, everyone. My name is Anuj, and let me begin with today's webinar on CMS 0057F. Also known as the Interoperability and Prior Authorization Final Rule, CMS 0057F was released on January 17, 2024. It emphasizes the need to improve health information exchange to achieve appropriate and necessary access to health records for patients, healthcare providers, and payers. This final rule also focuses on efforts to improve prior authorization processes through policies and technology to help ensure that patients remain at the center of their own care. The rule enhances certain policies from the CMS Interoperability and and Patient Access Final Rule, which was added, I think, somewhere in 2023, and adds several new provisions to increase data sharing and reducing overall payer, healthcare provider, and patient burden through improvements to the prior authorization practices and data exchange policies. Hence, the CMS 0057 regulation is sometimes also called as a burden reduction rule. We will see how it intends to reduce the burden with respect to the prior authorization current state in the further slides. In this webinar, we'll discuss about current prior authorization, impact on providers and patients on this new rule, affected organizations by this rule, the provisions of this rule at a glance, and then we will go into a little bit detail on what prior authorization API and standardization as part of e-prior authorization are all about. And at last, we will see what are the ramifications of these patients to the patients, providers, and payers, along with the timelines for the implementation of the same. Xyram Solutions has extensive experience in enterprise applications and services and software product engineering, with a focused expertise in healthcare IT, consulting, and strategic partnerships with EMR vendors and payers. Xyram's team include over 500 healthcare trained engineers who prioritize quality and interoperability in every healthcare project. Additionally, Xyram benefits from its sister firms, Drager, InteropX, Clock Health, and specifically talking about InteropX, which gives it a unique advantage by enabling some healthcare accelerators for interoperability, reducing time and cost for its customer. Xyram collaborates with organizations like yours, both in the provider and payer domain, from the initial consultation phase through to analysis phase, implementation phase, and ongoing maintenance and production. Looking at the current state of prior authorization, it is important to understand what is the problem in prior authorization processes and how does it impact patients. The AMA survey of 1,000 physicians about prior authorization put some hard numbers to prior authorization delays and costs, which includes 94% reported that prior authorization led to delays to patients' access to necessary care. 78% physicians reported that the process can at least sometimes lead to patients abandoning their physician's recommended course of treatment because the prior authorization is taking a lot of time. 24% reported that the prior authorization led to a serious adverse event for a patient in their care because a certain care could not be completed due to the pending prior authorization. Consider a child who is having a medical crisis in pediatric emergency unit, and physician is awaiting prior authorization for a medication to figure out how they can administer a medication to a 2-year-old when the insurance company will only approve the needed drug in a pill form. Imagine as a pediatrician with a child who is doing well in the school on a particular for a particular ADHD medicine, and now he can't find it because there is a shortage of it, and then you can't get the new one prior approved because it's not the one that's covered, even though there is a nationwide shortage of ADHD medications. Apart from the patient itself, there is a significant impact on providers as well. This slide shows some survey responses which highlights the impact on providers, specifically to the current state of prior authorization. It shows physicians and their staff spend around 12 hours each week on prior authorization. 35% of the staff work on prior authorization, and they complete around 43 prior authorizations on an average per week. 95% of providers report that prior authorization leads to significant burnout. And there are 27% prior authorization which ends up with denials, and only 18% denials are appealed because 62% of physicians report that they do not believe the appeal will be successful based on the prior experience. 48% report that the patient care cannot wait for the health plan to approve the prior authorization, so there is no point for them to go and appeal it. And 48% report that they have insufficient practice staff which can support the appeal of the denial processes. So there is a lot of frustration in the physician community as well around the current prior authorization in general. Looking at the affected organizations by CMS-0057-F rule, it has wide-reaching implications for multiple organizations across the healthcare landscape. The payer organizations specifically which are affected by this rule are Medicare Advantage organizations, state Medicare and CHIP FFS programs, Medicaid managed care plans, and QHP issuers on the FFEs. The rule requires these organizations to adopt new standards for interoperability, particularly focusing on data sharing and prior authorization processes. While the rule currently primarily targets these specific organizations, it is expected to actually influence all US health insurers in the future by encouraging broader adoption of its provisions to improve overall healthcare efficiency and patient outcomes. With respect to the providers impacted by this new rule, any hospital or critical access hospital who participates in the Medicare will have to um, utilize this rule when their EMR integrates it. And any individual physician or practice who participates in MIPS will also have a new report to along the prior authorizations submitted through this API or the prior authorization API. And those are the providers who will be impacted by this new rule. Looking at a rule at a glance, the slide provides some outline of timelines required for each provisions. By 2027, impacted payers must have systems in place to provide patient data via APIs, streamline prior authorization requests, and enhance communication between payers and providers. This includes using HL7 FHIR-based APIs for seamless data exchanges and public reporting of prior authorization metrics on their website, and reduce turnaround time starting in 2026. In addition, impacted payers must provide a detailed specific reason for the denial of a prior authorization request, whether the request was submitted via portal, email, fax, phone. Some impacted payers are also subject to existing requirements to provide information about denials to providers, patients, or both through notices. Additionally, we have a peer-to-peer API where there are provisions for payers to share data with other insurers if a patient changes coverage, promoting continuity of care. Providers and payers are encouraged to adopt automated electronic prior authorization systems to improve efficiency and reduce delay in care. The measures at the top, or the rules at the top, around prior authorization API, peer-to-peer API, provider access API, and patient access API are due January 1, 2027. While the reporting of the public prior authorization metric, which the payer has to put on their website, is effective March 31, 2026, the specific denial reasons and reduced turnaround times, which we will look in detail in the next slide, are due by January 1, 2026. Talking about the reduced turnaround time, the impact payers must respond to decisions to authorization within 7 calendar days for standard authorization and 72 hours for urgent authorization. In the left-hand side, we are trying to show what are the current timelines with respect to the standard authorization. Urgent authorization, I believe, are already around 72 hours, so there is not much significant change which has been brought by through this rule. But if we look at the standard authorization timelines currently in effect, we will see that's around 14 to 15 calendar days for most of the payer organizations. Those has been reduced substantially and now stands at 7 calendar days. With respect to the specific denial reasons, a specific denial reason needs to be added, which can be a standardized option or a standardized denial reason, which should accompany your denial and adverse determinations regardless of the submission method, whether it's e-prior authorization or it is through fax, phone, or any other manual ways of doing the prior authorization. The prior authorization metrics, the payers must report certain aggregated prior authorization metrics annually on their website. This includes standard and expedited request approval rates, request denial rates, and the overturned denials on appeal, along with the turnaround time. These are specifically coming in 2026 and are more related towards streamlining business processes other than the other ones in 2027, which involves development and changes and implementation to your current prior authorization framework. The other set of changes which are due in 2027 includes a lot of development and integration and changes to your current prior authorization process to support e-prior authorization, peer-to-peer API, provider access API, and patient access API. For payer access API should include information about prior authorization in the already existing patient access API. The patient access API, there were some rules which were brought in the previous 2023 provision already, which includes claims, encounter information, clinical data, including lab results, provider remittances, and patient cost sharing, like through EOBs, are already there in the payer portals for patients to look at. It should now also have certain prior authorization data added to it. And that should be request of the prior authorizations, which patients can see, and clinical and administrative data related to the prior authorization request itself. Metrics about patient access API usage should be reported by January 1, 2026 to the CMS as part of this measure. If you look at the provider access API that provides similar data access to providers like patient access API, which includes claims, encounter information, clinical data, and so on, it should also now have the prior authorizations which needs to be maintained. And that includes the payers will now need to maintain a member attribution process to associate patients with in-network or enrolled providers with whom they have a treatment relationship with. Patients can certainly opt out of their data being shared to the providers, and that's where the patient consent comes in. Talking about the peer-to-peer API, when the patients are switching payers, this rule allows for sharing of the data between the payers. Payer has to respond to requests from other payers, validate the member information, validate patient's consent, and then respond to the request. They also have to request data from other payers, identify the members, request the data, and validate the data received. As part of this rule, new payers' request for data is to be made within 1 week of the patient's coverage starting with the new payer. If a patient has multiple payers, then payers must exchange data at least quarterly so that the clinical information is shared at a certain interval. Patient still has an option, and it's mandatory for patient consent to be able to share the data of the patient across payers. The prior authorization API, which actually is the crux and 60% of the changes with respect to this rule, lies in this prior authorization API implementation. Providers can use the prior authorization API, we will also call it as a EPA, to determine whether a specific payer requires prior authorization for a certain item or a service. The prior authorization API will also allow providers to query the payer's prior authorization documentation requirements directly from the provider system. The prior authorization API should be populated with payers' list of covered items and services that require prior authorization, documentation requirements, and supporting the HIPAA compliant request and response as part of this API. And HIPAA is applicable for all APIs. With respect to the standards, the rule states certain standards which are needed to be followed to implement the rule. And that's where the standardization comes from. It includes HL7 Fire Release 4.0.1 and the USCDI implementation guide for US Core 3.1.1. It also includes the HL7 Smart Application Launch Framework Implementation Guides Release 1, which is specifically significant when the providers can now put the documentation requirements or the documentation which needs to be filled when the prior authorization is required can be hosted within the EMR's own framework using the Smart on Fire apps. There are certain recommended standards which has not been called as required, but it is very recommended even by Xyram to accommodate as part of your development for prior authorization API. And those are mostly HL7 DaVinci CRD 2.0.1 and DaVinci DTR 2.0.0 and DaVinci PAS 2.0.1. We'll look at what these CRDs, DTR, and PAS are there in the subsequent slide. Talking about the prior authorization API, it has three major phases or three major implementations which are required to be done. Looking at the CRD, which is also called as Coverage Requirements Discovery, it helps the provider to query the payer system to discover if the prior authorization is required. Is the member eligible for benefit? Are the ordered service a covered benefit, or the service provider is in network? All of these questions will be electronically answered through the CRD or the Coverage Requirement Discovery. If the coverage is there and the member is eligible for benefits and prior authorization is required, that brings to the second step, which is also called as DTR, documentation templates and rules. It standardizes the format and content of required documentation. and the implementation guide has specs for it, which CMS 0057 has recommended. With respect to that, whatever templates are required based on the specific requirements for that service, and defining the rules that specify the data elements required in the documentation, along with presenting that documentation templates and rules to the provider in a smart app, which can be embedded within their EMR, are all the considerations which are a part of TTR. The last but not the least is the prior authorization support. It compiles the necessary data, including the documentation and the rules, and creates a case in the payer system, which can later be returned as an authorization decision to the provider. And if it is a denial, then the specific denial reasons also needs to be communicated along with that. If we look at the ramifications for payers, providers, and patients for some of the parts or important portions of this rule, we look at the prior authorization API, which from the perspective of payers is obviously there is an impact because the payers has to implement the prior authorization API and send decisions to prior provider portal. They are the main enabler of this EPA or e-prior authorization. The providers needs to use systems which can implement e-prior authorization processes within context of existing clinical workflows. There are even recommendations in the guide where providers can integrate or their EMRs can integrate appointments, and while creating of the order or signing of an order can automatically request prior authorizations for those services. So there is an impact on providers. And of course on patients, because starting 2026, they will be able to receive public reporting on the prior authorization approval timelines across payers on their website so that they can compare their patients with respect to the denials and appeals and the turnaround time. With respect to patient access API, the prior authorization records must be available within 1 business day. And that obviously the payers has to implement the API, so there is an impact on them. Providers do not have any impact on that, but if we look at the patients, they will have access to the prior authorization data along with their EOBs and the clinical data as part of the patient access API. In terms of provider access API, the payers have to implement the provider access API, and hence they need to determine the attribution methodology, they implement the API itself, and consent framework on who the patient allows or to capture patient's consent. The providers can access the administrative and clinical data for their attributed patients, so it's obviously for their benefit, so there is an impact on them. With respect to patients, it does impact them because they will have to consent to what data they want to be shared with which provider and for how long. From the perspective of payer-to-payer API, the payers will have to implement the payer-to-payer API, so there is an impact on them. And the patients have to again opt in to share their longitudinal data across payers as a part of the patient consent framework. So there is an impact on patients providing consents as well. The faster turnaround time, which has been implemented, the payers need to change their business processes and optimize them so that the urgent requests are catered within 72 hours and standard authorization requests are responded in 7 calendar days. And providers obviously will benefit from this because they will have a faster turnaround time, at least for the standardized ones. And obviously, patients are the immediate beneficiaries where they will receive the care they need sooner because of the approvals. With the timelines being in 2026 and 2027, why there is a need to act now? If we start today, we need to understand your current system. The prior authorization is already implemented by every payer, and they have their own recipe, I would say, which implements, or their own workflows to implement the prior authorization as per their current organizational and processes perspective. Any optimization or enabling of the e-prior authorization requires to understand the current processes, understand the new requirements, and map them together so that you can optimize your current processes and make it enabling for this role. Hence, we help you with gap analysis and assessment, which is complementary as part of Xyram solutions, to understand what are the requirements, conduct the gap analysis, and submit an assessment report which helps the stakeholders like you to decide on budget, staff, and when do you want to start the implementation, and what's the planning and onboarding looking like. It might also involve build versus buy decision on e-prior authorizations, where you can do it yourself or you intend to use an existing system. If we start today with the gap analysis and an assessment, being almost the end of the year, we will be able to at least rationalize the decisions through the assessment report. And coming into the new year, can start thinking about the project planning, PRD documentation, which is the requirements, and the development itself of those prior authorization and provider access and patient access APIs. Subsequently, by March, which would involve the timelines towards June, where we will have to think about how providers will integrate with the system, because they have to implement e-prior authorization and connect to the e-prior authorization APIs and provider access APIs. And that's where the benefit lies. So there is a provider engagement which needs to be done and which needs to be enabled. The UAT and system pilots which needs to be done, and then pre-prod and other governance, compliance, security assessments needs to be done before it can be put for the final launch. So do the timelines look, they are in January, they are in 2026 and early 2027. We believe that it's time for payers to think about implementation now so that they have more time to think about provider engagement and sharing of data with providers and testing with their systems. How Xyram can transform your journey with the CMS 0057 rule. I had already spoken about the 500 plus healthcare resources which Xyram has, and 100 of them are fire specialists, which is a required standard for this implementation. Xyram will provide you a complimentary gap analysis and assessment of current systems. It comes with a deep understanding of the current third-party prior authorization standards and systems. It also understands payers very well, as it has implemented various other implementations along with prior authorizations for various payers. Since we have fire specialists, we'll make sure that your design and expertise, your design is within the recommended standards and futuristic in nature. Xyram will do an end-to-end implementation starting from gap analysis to the production, and you will have throughout an access to all the experts on the prior authorization. And then you can also compare the challenges. Proven benefits in implementing the CMS 0057-F rules for payer organization is an additional differentiator because of Xyram's ability to work with medium-sized and large-sized payers and the work they have already done on e-prior authorization with them. You want to hire an organization to implement this change who understands your prior authorization policies and processes and integrate the e-prior authorization on the top of that to enable the providers to access the data electronically. And that's where Xyram can help you. With that, I would move to questions.
Thank you so much, Anuj. That was an insightful session where I'm sure everyone have got very good understanding of what CMS 0057 rules are and how Xyram helps to implement it. Thank you so much. With that line, I see there are some questions from our audience. I would like to put it across. The very first question is, it seems patient opt in or consent is necessary for many of these measures, whatever was explained. How will this be implemented?
Yeah, that's a very good question. So I think if we go back to the slide where we discuss the impact on payers, providers, and patients, we already see that the patient consent is a requirement, and HIPAA also enforces it for the provider access API and peer-to-peer API. In both the cases, patient is currently already on the patient portal for payers for the patients, which payers have implemented, where they see their current EOBs and any communication with the payers. And the idea is that probably the payers will enable the consent from the perspective of the provider access API and the peer-to-peer API, somewhere by providing notifications around the patient consent or provide consent or sharing of information access to this provider and that payer. And that's how we see that that is a way where we can implement the changes. There are several other things as well which will differ from payer to payer, and that's where the gap analysis is important as well. But we see the point where the payer and the patient access is enabled on the payer's website or portal is a way to allow patients to consent to certain data, and payers has to facilitate that.
Okay, that was nice. Thank you so much for making it very much clear. Let's go to next question. Other than faster turnaround time, it still doesn't solve problems with confusion around what services will need EPA and denials. How does this rule helps in reducing such confusions?
Right. So the rules is significantly helping you with respect to the reduced, especially providers, is helping by reducing the turnaround time for the standard prior authorization request and for 72 hours for the urgent ones and 7 calendar days for the standard ones. When enabled with e-prior authorization API, our understanding is that while a provider makes an order or signs an order, the e-prior authorization API can be integrated as part of their workflows, so they don't have to specifically look for doing a prior authorization separately. That saves a significant amount of time and energy for the payers to understand whether this service will require prior authorization, because with every signed order, they can call the e-prior authorization API and get a response whether it's in the list of services which needs prior authorization or not. If it doesn't, then the system doesn't have to do anything about it, and the patient can receive immediate care. If it does require prior authorization, then the system will automatically create a workflow in the system to do the CRDs, the DTRs, and PAS, some of the things which we have already discussed as part of the e-prior authorization API workflow. And all of that process will be electronic in nature. So that's the way this rule is helping. Now, with respect to the denials specifically, since the documentation are templates, which prayers will provide as part of Smart on Fire app within your application, and the rules will also be put into that through them, it will be a software which your company would be using to answer certain documentation questions and responses which you need to fill in. So a lot of things about finding what documentation do I need to fill will specifically help with reducing the denial for this. And that's how I believe this will help in significantly reducing the burden And future rules will obviously solve other problems as well. Thank you.
Okay, that was great. Another interesting question I have is, as a provider, what should I ask from my HR vendor to benefit from this rule?
Yeah, again, a very good question. So, as a provider, all the things and implementations as part of e-prior authorization is important for payers to be able to do that and required for them to be able to do that. But what's in for providers other than just accounting it as a MIPS measure for how many prior authorizations they have submitted? Well, the provider should be asking their EMRs about when and what is their roadmap to integrate with the e-prior authorizations and to integrate workflows like radiology orders or your computerized provider order entry module. When you sign an order, the prior authorizations for the services is automatically done, and the implementation of e-prior authorization API with the payers which the providers work with. If you ask these questions with the EMR, it will be very helpful for you to know to actually take benefit of this rule which payers will implement, because only then and then you can attest to the e-prior authorization API requirements for the MIPS measure, and as well as provide patient care for you and take help from the burden reduction rule towards a more focused care, caring less about prior authorization and its extended timelines.
That was good. Thanks for the answer. Okay, Anuj, since we are at the end of our time, there are certain implementation level questions that was asked by your audience. I have texted you all of that. Can you please summarize all of those?
Sure, let me take a look at that. Okay. Yeah, so I think that the audience have already started asking some of the implementation level questions. And I think if I have to summarize them, the questions specifically ask about what is the tech stack which needed to be used for this rule and which will be compatible with my IT landscape. Another user asked about what kind of resources are required from the payer organizations to commit to these changes, and whether there will be any downtime to their current prior authorization systems. And they're very, very good questions and very specific and focused on implementation. And that's what we want to answer with gap analysis. All of these questions around the tech stack, because your tech stack doesn't need to change. If you're on cloud, you could continue to be on cloud. If you are, on premise, your systems are on premise, then you can continue to be doing that. Or it's hosted wherever it's hosted, and nothing needs to be changed with respect to the tech stack. But the required standards and their implementation is what the gap analysis will help us to answer whether your current tech stacks comply with everything what this measure is asking for. But obviously, you have to implement the recommended standards. Now, what kind of resources and any downtime required? Well, that again will be answered through the gap analysis, because we will have to understand what are your DevOps strategies for production deployment and other features which can help reduce downtime. And if that is available in the current framework, that will obviously help with that. That's about it on those questions. Okay, I think with that, thank you everyone for participating in this webinar. Over to you, Shilpa.
Great. Thank you so much once again, Anuj, for this exclusive webinar and providing us all the insights related to CMS 0057.